Hey everyone, just wanted to take a moment to thank you for listening to the show. We're thrilled that you're here and enjoying the content. This podcast is completely free for you, but if you'd ever consider supporting the show, we truly appreciate it. One way you can do that is by using our affiliate links. These are links to products and services that we've mentioned on the show. And if you make a purchase through one of them, we might earn a small commission at no extra cost to you. It's a great way to show your love for the podcast and help us keep creating awesome content.
Blah, 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 blah.
Welcome to the Our Forever Smiles podcast, a podcast created to support mothers of children who were born with clefts and those who love them. I'm your host, Laura Arroyo, and I'm also a mother of a daughter who was born with a surprise cleft palate. I know the challenges you face every day. Whether you have just learned the difficult news of your baby's cleft lip or palate, you're in the midst of pre-op or post-op, or you're an OG cleft mom, this podcast is for you. In a weekly conversation, we will talk about everything from feeding and speech therapy to surgery and school. We'll share tips from guest experts and advocates, and even share a little joy in the process. You can listen to Our Forever Smiles wherever you listen to podcasts. Don't forget to subscribe and stay tuned. Hello and welcome back to the Our Forever Smiles Cleft Mom Diaries and Support podcast. I am Laura Arroyo. Before we jump into this episode, I would like to invite you to join this community to hear conversations with other cleft moms and advocates that will help you feel supported along your journey. All I want you to do is click on the Facebook group page that is linked in the episode notes. You can speak directly to the guests from this podcast, ask questions, and talk to a community of cleft moms that are eager for answers, but also willing to help. As a note, while we do have a cleft surgeon on the podcast today, Dr. Ruotolo is not your cleft surgeon, so we do not intend for you to use the information that we share here as medical advice. We're parents and advocates who love our children, and we're sharing our own personal experiences. If you would like to share your story on the podcast, please feel free to reach out to us at ourforeversmiles@gmail.com. So, I have so many questions today, so I don't want to take up too much time doing a weekly recap of Giselle and I. And as you heard, we have a guest today. Dr. Ruotolo is a pediatric plastic and craniofacial surgeon, as well as a partner and vice president of New York Plastic Surgical Group. She is the co-director of the Cleft and Craniofacial team at CCMC. Welcome, Dr. Ruotolo.
Thank you. I'm happy to be here.
Thank you for being on today. As I've shared before we started recording, we've had several conversations with cleft moms sharing their experiences, but we love, and I wanted to invite cleft professionals on the podcast to not only share about their passion for this field, but also just to get some insight to see like the overview of the cleft journey and what that means in terms of what families can expect during the surgery journey specifically. I feel like that's a really scary thing that families have to go through.
Yeah.
And it's just really tough.
Yeah.
And also, I feel like we don't know what to ask. I remember like when I first had that first conversation with my surgeon, and of course, right, if you're a good surgeon or a good medical professional, you say, do you have any questions? And in the moment, we're like, I have lots of questions, but I don't know what to ask.
Yeah. Yeah. Did you meet your surgeon first prenatally or after?
So my daughter actually surprised me. And so we did not know until she was born. And so, and she's cleft palate affected only. And so that's why they didn't pick it up on the ultrasound. She met Giselle, that's my daughter, I think Giselle was probably like 4 weeks when she saw her.
Okay.
That was.
Yeah, I think that, I have a combination of parents and moms that come to me. Some come with a whole lot of questions all written down. And there are plenty too that just don't know, like you said, what to ask. So I think usually, especially when I meet the moms prenatally, I love when I'm able to do that. And again, you're right. Like if the baby has a cleft lip, that's usually can be diagnosed prenatally, but if there's just a cleft palate, it's not. So when I have the opportunity, it's nice. And a lot of times when they have the diagnosis at that 20-week-old, the internet and scary stuff. The internet is great, but there's a lot of information, but a lot of misinformation. It can be scary. So I usually start out the consultation just by giving. I do ask them before I start. Do you have any? I'm just going to kind of give you a broad overview of what to expect, and usually that's how I start. I just go beginning. When the baby arrives, I always tell the parents we don't know exactly what the baby has until the baby gets here. We can, tell some things from the ultrasound, but not everything. So when the baby gets here, either myself or someone from my team will meet the baby, and then I take them through from day one, all the way through that first year, really, and then also beyond that, and just give them kind of a broad view of what to expect. And then following that discussion, I open it up to questions to see if I didn't address something, anything specific, and then they're provided with my contact information. The consultation, it's common to be a little overwhelmed, right, with all that information. There's a lot of emotion and it is going into the conversation and all the feelings that the parents have. So I say, when you leave here, if there's something I did not address or something comes up along the way, contact me and I'll answer it then. And I also invite them to come see me again anytime before the baby's born. So it allows them several opportunities to ask me questions along the way.
I love that. Sometimes I think back at my journey and I'm like, do I wish I would have known earlier? Or was it like, did I learn at the right time for me, right? Because I think also, just as you mentioned, the internet can be really scary. And so it is one of those things that
Well, I think that there's pros and cons to finding out early. I think the pros is that you're not surprised, right, after delivery and you can prepare yourself, but that's also a con where, some moms, that second, because they find out at 20 weeks, they have half their pregnancy left. And then a lot of that pregnancy is spent worrying, right, and not enjoying the whole process of being pregnant for some people. So that's taken away sometimes. And in that prenatal consultation, I hope to accomplish reassuring them of all of this so that they can enjoy the remainder of the pregnancy. And I do try to emphasize that when I talk to the moms, like, to please just enjoy this process, enjoy being pregnant, feel good, and everything's going to be okay. So, but I can see both sides, knowing and not knowing.
One of the reasons why I reached out to you specifically is because you do a lot of like documenting and stuff online. And it's the first account that I've seen in this way. And it's just very real and like raw content. And you can actually really see these before and after pictures. And even I love that you do like the markings and stuff like that. I feel like it's really cool. And so, and I mean, I don't know if it's a lot of work. People don't realize that's not something that you have to do, right? It's something that you're doing so that people can have the information, and just the setup and the cameras and all that. It's a lot of work to do that. Yeah.
It's a lot. Oh yeah. It takes a lot of, but you know what? It's the Cleft moms that are the ones that encouraged me to start my social media platform years ago, because I don't do it personally. I still don't. And I had no experience with it whatsoever, like Facebook and Instagram. And so it was a little daunting because it was something that was unfamiliar, but they asked so much, so many times, and because they wanted to share their children's story to help, enough. And I think I started in 2000. So it's just grown. If I look back into my original posts and now, it's definitely grown. And I think the markings, for example, that you mentioned, so it's funny, like some of the comments that are made, you think that we're all surgeons, like looking at this. And that's really not, it's actually, I find like a lot of the parents are very interested in seeing what goes into their child's surgery, but also it's something for surgeons too that don't have access to. So now I did medical missions years ago and I will do them in the future, but now it's just not the time for me to do that. But it's a way of me reaching all of these other medical professionals in the world to show them and teach them and help them perform these surgeries. there have been a lot of requests for me to actually show the surgeries. I can't really do that on social media. I'll be blocked right away if there's any like incision blood, whatever. So I've had to answer people because they want to actually see the surgery. I'm like, it really, like those platforms won't allow me to do that. And what's really interesting, because I get a lot of questions about cleft palates, right? They ask, because I show a lot of the lips, but not so much about the palates. And I did on my prior post, they get blocked
Really?
all the time. The photographs for the palates get blocked because they misconstrue what it's a picture
Yeah, I
of.
wondered that.
So because I think it's an algorithm that, because a person, right? People can't monitor what everybody's posting, right? So it comes up, as something that is,
Yeah.
and like honestly, that they think it's
Yeah.
gynecological. Like they think it's horrible. And I've appealed them and said, no, see the teeth, see the nose, it's a mouth, it's a uvula, this is not. Then sometimes they will unblock it. But I do want to talk more about palates and show repairs. But every single time it's just, I hit a little bit of a blockade. I'll still try, but
Yeah.
that's been a challenge. And because a lot of parents have been asking me to show more about actual
Yeah,
palate
that's a big
repairs.
one. And I plan to ask you a little bit more about that, but I want to rewind a little bit. So my daughter was born with a cleft palate. And so I never knew that this was going to be like my passion work, right? I had no idea that this would happen to me. And so what got you into this field? What made you start doing work on the cleft community in this field? Yeah.
So, I mean, it's definitely a long road, as far start off like graduating from high school into college and med school and resident, etc. So you have a time to figure out, be thoughtful, and think about what interests you the most. And it really comes down to you like weed things out, right? I knew I wanted to be a surgeon. You start there, and then you go into all the different specialties and figure out like what you're most interested in. Plastic surgery in general interested me because of the technical aspect of it. It was very detailed oriented, very meticulous. I liked that. I liked that you see results right away, right? You look at whatever surgery you're doing, like you look at something, you're changing it right there, right away. So the actual surgery aspect I loved. And then when I was in my plastic surgery residency, I paid attention to the surgeries I most looked forward to and most enjoyed. And it was the craniofacial surgery. So this part of the body is what interested me much more so than, body surgery. So the anatomy I liked best. And then it was the patients, it was the little kids. As a craniofacial surgeon, you operate on little babies and you operate on all through life to the elderly, depending upon what you're doing, because we do a lot of facial trauma, post neurosurgical reconstruction. It was amazing that I was restricted, as to I got to take care of everybody. And from head to toe, as a pediatric plastic surgeon, I operate on all parts of the body on children. And then, so you keep going along, right? And then I start practice. It was just, it's just, a passion of mine. And the wonderful, wonderful part about taking care of cleft patients and their families is that you grow up with them. It's really one of the few things, like I meet a lot of these families before the baby's born. And then you grow up with them. I take them until they're adults. I mean, I've been doing this 17 plus years. So my old patient is, going off to college crazy. But you get to see them have more kids, the parents, and you get to see their siblings and you get to see them grow up. So I think that's just awesome. That's an awesome part of
that's fascinating.
doing this.
I actually recorded an episode with a pediatric dentist, and it's Dr. Holguin, and she's in El Paso, Texas. And she said the same thing. She mentioned that being able to watch the families grow and just being with them for so long it's really rewarding, I guess, to just watch all of that. And I can see how that you can become passionate about them.
I think that's just what's unique to the field, honestly, is, where with other types of surgery that you do, you operate on them once they've healed from the surgery, you don't really see them again. But this type of surgery, you take care of them for a
Yeah.
very long time.
So speaking about pediatric dentistry a little bit, do you require your patients to do the NAM program or taping at all?
Yeah, but only certain patients. The patients that have a very wide cleft, so the lip segments are far apart, the nose is very flat and misshapen, then they benefit a lot from the nasoalveolar molding. Now, some patients come from far away, it's not possible, and some babies don't tolerate it, or the parents can't make those weekly visits. And in those situations, I'll do a lip adhesion or a staged lip repair. And then some babies that have a more narrow cleft lip and the nose isn't that distorted, they don't require the nasoalveolar molding prenatally. It's a lot for parents to do. It is a lot. It's very stressful in the beginning, especially with feeding and the nasoalveolar molding and those. So I try to make it as easy as possible for the parents and make all their, try to help make all their appointments for them, arrange for the appointments. They see me and my team weekly for weight checks, make sure the baby's feeding properly, go over feeding with them, feed with different bottles. So we do a lot of that in my office with my team to try to make it a little easier. But nasoalveolar molding is definitely a part of the treatment program for my patients, but not all of them require it.
I've heard I've not only spoken to some cleft moms that have gone through that, and my body physically tenses up just thinking about having to do that.
I know.
And
yeah.
I empathize with those mothers that have to go to those weekly appointments. And I mean, my daughter was born with a cleft palate, and the appointments were a lot for me, and she only had half of them. So it's
right,
tough.
Especially when they have other kids, and it's a lot. It's a lot, or they live far away, or they don't have easy transportation. It's really onerous, and that is a challenging part of those first 3 months.
And so let's say, would you say that if a mother chooses not to have the NAM, you would have better results if you got the NAM versus not being able to do that?
So it's hard to say because you don't have, so the thought process behind it is, yes, it helps bring the lip segments close together. And if they're closer together, there's not as much tension and the scar will look better. And also the nose, it optimizes the appearance of the nose. But that said, I've done it successfully with patients that haven't had it. So I don't think you can't get a good, if you don't have it or don't use it. And then with the cases, I do that staged lip repair. In some of the severe cases that can't have NAM, I will convert a complete cleft lip to an incomplete and then do the definitive lip repair several months later. That is also an option for parents that can't do the NAM.
I've seen the adhesion, but I've never seen a staged lip repair. What does that entail?
The staged is the lip adhesion. So I have it on my Instagram and TikTok, platform, and Facebook. It'll show like the different stages. So it basically takes a complete cleft lip, and the adhesion is where you're just basically partially bringing everything together. It's not the definitive repair, and you're converting a complete cleft lip to an incomplete. You let them heal for about 3 to 4 months or 6 months, and then you perform the actual lip repair. And I put nostril retainers in at the time of the lip adhesion, so it helps mold the nose or shape the nose. So it accomplishes a lot of what the NAM does accomplish, but it is a surgery.
So parents probably opt to do the NAM over that to have one less surgery sometimes.
Sometimes, but some it's just they actually physically can't get to the facility at weekly, and it's just not an option for them. Or the baby doesn't tolerate it. So some will opt for the surgery.
What do you find is like the main concern for families when you first see them? What's the, I guess, first question or top question?
It's different for different families. Some obviously are worried about what the baby will look like and their future. And some worry about the teeth, and some worry about the speech. And a lot of parents worry about if they're being normal. And that's also a huge part of the conversation, is that 99.9% of the babies I take care of are absolutely normal. Yeah. And I try to emphasize with the parents that as, upsetting as this news is for them to hear, right? There are so many babies that are born with things. They externally look normal, but they have things going on developmentally that we can't fix. And this is something we have tools and the expertise to actually fix. So I try to focus on that. Like this, yes, although you wish your baby didn't need these surgeries, we have really, really good surgeries that will allow these babies to have absolutely normal lives.
That was one of my major concerns too. And I was actually, my first appointment with my surgeon, she looked at her and, of course I'm a mom, so I'm like looking at all these like little cues, and I'm also like postpartum, so I'm a little wild, like I'm a little woohoo. So yeah, I was picking up things that they were saying to each other in the room, and she said, "Oh, she has a small jaw," and then she says, "We're gonna refer her to genetics." And so I'm like, "What does that mean?" So of course the next day I'm like Googling and stuff, and so then I came up that after I Googled, I saw that, oh, she's thinking that she has PRS. But she probably couldn't say that to me because she doesn't know, right? And she doesn't want to scare me.
Yeah.
So she had her genetic testing, and it turns out that's just her anatomy, but she doesn't have PRS. But it's one of those things that's just like that initial appointment. It's really,
Yeah, I mean, that's there's a lot of genetic testing that is done prenatally, right? But there's some postnatal genetic testing, and those are some of the appointments I help set up along with ENT and dental and all of that. But yeah, genetics, those questions I get, obviously parents are wondering, moms, what did I do wrong? They have all these questions. Oh, I like fell, when I was months, or like they remember like all these little things, and I try to reassure them as best I can that something that they did at all that caused this. It's extremely common. And there's genetic factors, environmental factors. We don't have a good handle with all the research that has gone clefts. We still don't have a good handle on what causes it. So, because obviously there's a mom's guilt that is a big part of this.
I mean, have you had moms? Because I go through this is just what you said has what's always been told to me. Right? It's, you didn't do anything to cause this. Because again, like myself, I'm like, well, I was drinking pre-workout because I didn't know I was pregnant, and I was like exercising. I'm like, maybe it was that. I'm like going through all these things. But I've relinquished any guilt just from talking to so many people and so many professionals. But I guess, we do plan on having a genetic counselor on the podcast to clarify these things. But people can go down deep rabbit holes about all of these things. And so based on what you know, so they haven't found any definitive answers from what you've seen.
No, and there's some genes associated with it, but you can have the genes and vice versa. So no, but we know when it happens, when it declares itself in gestation, but like 9 to 12 weeks. But other than that, I have identical twin babies in my practice that have different clefts, have a unilateral and a bilateral, or one has a cleft and one doesn't. So in that case, clearly it's not genetic, right? Because they're genetically identical. So there must have been something environmental in utero that happened.
And when they're saying environmental, does that mean, and then what people think is like she was smoking,
like a blood supply issues or something like that, not environment like
or
smoke,
drug use,
like you
or
said,
or
yeah, right, correct, because that would affect both
Yeah.
babies the same, right?
Thank you so much for that. Because I feel I've spoken to a ton of cleft moms, and I push back on a lot of things. And then sometimes I think, well, maybe I don't have all the information that I need to have to be the voice of this. And so again, that's why I wanted to bring on more professionals that can say, hey, listen, like this is what's going on and this is what we know. So I really do appreciate that. And in terms of cleft palate surgeries, so we talked a little bit about cleft lip. For cleft palate surgeries, I've seen like varying incisions that are done. How do you do your cleft palate surgeries, or does it vary?
It varies a little bit, but by and large, I do the furlough, double opposing Z-plasty, soft palate repair, and then my hard palate repair is either a von Langenbeck or Bardock, depending upon the width of the cleft. But essentially, those are the three techniques that I use, but the actual incisions and technique varies because the anatomy is completely different in every single baby. So you have to change and adjust what you're doing to adjust to the anatomy of the baby you're operating on. That's what I find so rewarding and fascinating by the surgery that I do is no two surgeries are the same.
I think my daughter, the way that it was explained to me, she took tissue from both sides of her mouth and then brought it together in the
Brought it
midline
together in
and
the
then
midline.
had the incision
Yep.
there.
Yep. Yeah, and all those techniques you're doing that. You're making incisions laterally and to mobilize it medially to bring it
I find
together
that to
and
be so
close it.
fascinating because to me, I was thinking to myself, like, how does it stay up? But maybe that's a silly question.
Reattach everything, like all like anteriorly, and then it stays together posteriorly. Yeah. So no, it's a great question. And then in those incisions that you make on either side, those are open, right, to close the midline, and then the body makes new mucosa within 2 weeks. So that's
So then they have those openings, and then is that why usually, well, let me not say usually, this was in my experience, they saw her 2 weeks later. So is that what you all are looking for, is to make sure that's healing properly?
Yes, I also look for the sutures down the midline in order to advance the diet. So, meaning I put those little arm restraints on them, the no-nos, the elbow immobilizers, only if they're thumb suckers and they put their hands in their mouth. So I look at it for that. So if it's like all the sutures are dissolved, everything looks well healed, then I'll take those off. Or they can start eating more. I mean, I let them have purees right after surgery. They're drinking with their Cleft bottle. So usually I wait till week 4. So I see them mix in 4 weeks. And then the elbow immobilizers come if they have them, and then they can use a regular bottle after that if they want to. So all the sutures are dissolved and everything's healed, and then you don't worry about any stress on the repair at that point.
And so this is, I think, a question that a lot of us have. So many moms panic about getting their baby off the bottle before repair.
I don't understand that. Some moms that come to me from far away have said that. I mean, and also I guess some moms hear about this when they are on these mom groups and stuff. But no, they can stay on the bottle for sure. Like my only requirement is they have to use the Cleft bottle. They can't use a regular bottle yet because you don't want them sucking hard against the new. But no, absolutely, they all are bottle fed.
So in my case, we were told that she had to be off the bottle before repair. And it was, I wasn't like really, my personality, I try to remain calm, right? So I just try to chill out. But it was, okay, it was something I knew I had to do. And so I practiced with her a bit, but I wasn't going to stress out about it. So we got her off. So I'm going into debt over sippy cups, but it's, this.
You have cabinets filled with.
And then you're right. You go in these groups and like, what's the best one? And like, you're just trying to figure things out to be like as prepared as you can be.
Yeah.
But then, so she has her surgery, and then my surgeon, she says, yeah, she's okay to use her bottle. And so I'm like, I like wouldn't have been like freaking out over this so much if I knew that. But I think I really love my surgeon. She's wonderful. But I think that she just wanted to prepare me for the worst if I couldn't use the bottle anymore or something. But she did. She cleared me for the bottle after. But my daughter didn't want anything to do with it anyway. I had to syringe feed her.
Yeah.
And so one of the things that I didn't do well, and I'm lucky because it turned out fine, is my daughter was a thumb sucker. That's why I laughed when you said she was a thumb sucker, but she is so miserable with the no-nos on that she couldn't even sleep at night with them on.
Things called cozy coos or cozy, something like that. One of my moms got for her daughter, and she said, if this doesn't work, I'll definitely use the no-nos. So I've suggested that to some moms, that when the baby's like completely hurts, they're like hungry, nothing feels normal.
Yeah, she also didn't like to be swaddled as a baby, so I knew. I mean, when she was first born, she didn't really care for the swaddle, so she wanted her hands. But I didn't let her suck her thumb or anything like that afterwards. I just monitored her closely and, of course, lost a lot of sleep in doing that. But yeah, so I guess the way that people describe like palate surgery is that I've heard people describe it as like a wet tissue. And that's why we're really careful about putting anything in their mouths or anything like that. Was that an accurate description of that?
No, I think it's just that you have all these open wounds and these incisions in there, and you don't want any, and these fresh incisions that with all these fine sutures, you don't want those sutures pulled out. You don't want them like if they suck their thumb, they could push right through that midline of the repair. It's more that. It's more the incisions than the type of tissue it is.
I
And the kids can be pretty forceful with their thumb
yeah.
sucking. They can definitely cause some damage there. So I always ask the parents preoperatively, and I watch the baby in the office if they're constantly putting their hands in their mouth. And it's usually the timing of surgery is usually around when they're teething. So oftentimes they want to put stuff in their mouth. So a lot of the kids, they do get the elbow immobilizers, but I found that they usually, not every baby, but most of them
Yeah,
tolerate
I've
them
seen a
pretty
lot
well.
of moms online. And then, of course, I've seen a lot of people ask, like, how do I get my baby to tolerate them? But I guess it's like with anything, right? Like the first day, they adapt, they adjust really easily. I think the first day is always, they can't
Yeah.
use their arms anymore. So, of course, they're going to be like, what's happening? And they just adjust.
Yeah. I mean, that's what's great. That's what's great about operating on babies too, is that they're so resilient. They honestly are. I mean, you can't do to adults what we do to babies, and adults will be like so miserable
Yeah.
and complain all the time. Babies are just like, they just go with the flow. They really adjust quite quickly. It's amazing. They're
Yeah, for
amazing little
sure. I
people.
always say like she did better than me, but this whole thing I was always like constantly worrying and just had so much anxiety and just it was a lot. And it was a lot for her to
Yeah.
go through as well. I what percentage of or how many palate repairs fail? I feel like that was a big worry for me as well.
It's rare. It's rare. But again, it's so important for parents to seek out a surgeon that is, doing a lot of the surgery and primarily doing the surgery else, right? Like surgery is, they say to become an expert in something, you have to do 10,000 hours of it, right? So you want to go to somebody that this is what they're doing and they're doing a lot. So that increase of success, that it's not 100%, nothing's 100%, stuff
Yeah.
happens, right? Infections can happen that can break down the repair. There could be an issue where traumatic issue, right? Where something goes in the mouth. It's usually infection or some trauma that causes a dehiscence or breakdown of
Yeah,
the
that was
palate
going to be my
repair.
next question. Like, why do they fail?
That's usually the reason, or if there's a very wide cleft, there's a lot of tension on the repair that will cause a fistula or a hole within the repair. Those are all things that can contribute to fistulas or failures.
Do you do the bone graft surgery as well?
I do. So it's interesting. So I was trained to, but when I came to New York, the Cleft team that I joined, the model was that the oral surgeons do the bone grafts. So that was just how it was done. And I was working with the team, so I wasn't going to, I just wanted to work with everybody well. And they were great. Awesome. They're awesome surgeons. So they've been doing all my bone
Okay, so
grafts.
you would refer them for a bone graft or
Our
oral
oral
surgeons.
surgeons.
Okay.
Yeah.
And then I'm just curious because I've just noticed a lot of people have really different experiences with cleft teams. And so do you lead the charge and you need to be referred out? Obviously not you, but like your team, or you're the center point of this is who you talk to for speech and this is who you connect with for genetics and that type of thing?
Yes. So when they're in my office, I'll refer them to those individual doctors. I usually don't have the kids see our cleft team until they're about 2.5. So they come to our team visits, which is once a year, because at that point they're starting to talk and there's all of those developmental issues, or because it's the time where the parents really need support. And they need to be evaluated by everybody. I feel like prior to that, it's not necessary. They get a lot of their care through early intervention too, and there's early. And they see the ENT as needed. So it's really at 2.5, they start seeing the T yearly. Because very soon, when they're 5, they get X-rays to evaluate whether they need a bone graft, and then they're seeing the dentist and they're seeing the orthodontist, and then that wide period of time, from say 5 to 12, a lot, and so it's easier for the parents too to see everybody all at once at our
At
team
our
meetings.
first cleft team meeting with my daughter, the pediatric dentist was on the schedule and they came by and they're like, oh, she has no teeth. But it was good. It's
Oh,
kind of
yeah.
like, okay.
Yeah. Yeah, that's
Yeah.
why sometimes it's too early. Yeah. So I just arbitrarily pick the age of 2.5 because I feel like that's when it's like most needed. I feel like prior to that, there's not, other than introducing the parents to the whole concept, I feel like there's not a
Yeah.
huge value to it. But some parents have wanted to meet the team early on, and they can if they want.
The one thing that did come out of that is I didn't realize the first tooth, first appointment, or just learning, just understanding what I should do when the tooth comes. Just the basic concept of brushing.
Oh, yeah.
But so do you have people that travel a lot to come see you, or is it mainly just people in New York?
Yeah, I do actually. I mean, obviously a lot of my practice is from like the area and tri-state area and drivable, but a significant number, as especially lately with my outreach, coming from really far away. So that's really super
I
exciting.
love that. What is like the biggest mistake I think, or you think families make in this journey?
I don't think, I can't think of mistakes they make, honestly. I don't know. I can't really think of one. I think I do try to caution families against over researching things online because there's a lot of misinformation there and it's hard to decipher between what's real and right and not. So, but I wouldn't say that's a mistake. I would just say that I like caution them from doing
for
too much
sure.
of that.
Yeah, that was poorly worded. I don't know whether it is a mistake, but not necessarily a mistake, but more so, what would you caution them against, right? What's something that didn't work for them? And that's a good one. I think people do overly research, and some of it is beneficial. It has been beneficial to have like support, and that's like really why I've started this as well.
Yeah, and I encourage the parents to talk to other cleft parents. There's a lot of parents in my practice that are always happy to speak to families. So I encourage that to so they can get a sense of what to expect from actual families, not just hearing it from me. And also to things that, especially for the cleft lip parents, is that the actual surgery is hard for them sometimes. They fall in love with the baby's face the way it is, and then I changed that with that surgery. So people commonly think that, oh, the parents just so happy when, right after the surgery, but it's a mixed emotion for the parents because the baby looks
I've
different.
heard that time and time again. Yes, I've heard that people grieve their pre-op smile and even they come down the corner to finally see their baby with their repair, and it's like they don't recognize them, right? It's like they're not prepared for that moment. So that is one thing that people have mentioned to me as well. But just in closing, I feel like you've shared a lot here today and given us a lot of information that I truly appreciate. But out of all the things that you said, or maybe you have something new to share, but what is the best advice that you would give to a mother of a child that has a cleft?
I think that the best advice is that the baby is normal and can focus on the fact that I think it's just that all the worry that these children and looking, especially I refer them back to my patients and looking at them on all of the posts that I have. These are normal kids, they have normal lives and normal families and they have normal experiences. And it's just that they need a few surgeries, some more than others, some one surgery, some two, some a few more, but that they're normal kids that live awesome, fun, happy lives. And I think that's the best advice I can give. I mean, it's hard though before they've started the journey to actually see that that's possible. But I think referring them to actual patients and parents, and I think that's the benefit of the post too, is just they see these kids that I've taken care of over the years and see them in their activities and doing things and living happy, normal lives.
I like that you mentioned that clefts are as common here in the United States as they are everywhere else. And I think that really helped me quote unquote normalized, right? That this isn't just so far out of reach. We see a lot of different images online, and that can be really scary, and it can make you feel like, oh, you're not normal, right? You're an outlier
Yeah.
or something.
Well, the image that people have in their mind are those images on the sides of buses, right? From Smile Train, Operation Smile, of 3, 5, and 5-year-olds with unrepaired clefts, right? With like teeth. And it's like a daunting image, right? And because people don't see that here in the States, they think it doesn't happen here. So the difference is that we repair these so early, the lips at 3, 4 months and the palates at 9 to 12 months. So we don't have kids in the States walking around looking like those
Yeah.
pictures that they see. So because of that, people think it doesn't happen here, but that's the case at
Yeah.
all.
And you can go on and live a wonderful and beautiful life. So I appreciate you so much, Dr. Ruth.
You're welcome. You're welcome. My pleasure. I'm happy to talk to you, and hopefully some of the things that we talked about will parents and moms
For
will
sure.
find
Thank
helpful.
you. And thank you all for listening to the Our Forever Smiles, Cleft Mom Diaries, and Support podcast. Be sure to subscribe and submit a review of the podcast wherever you listen. I hope that you've enjoyed this audio experience. Maybe you cried a little, laughed a little, but more importantly, I hope that you feel a little piece of reassurance and even joy in your journey. Love always. Talk to you next week.